I'm here to present the journal club for today. The topic for today is neoadjuvant nivolumab plus chemotherapy in resectable lung cancer. This was published in the NEJM on 11th of April 2022. Now, before we begin, let us see the background behind this study. One of the earlier questions was how early does the recurrence occur in Nsclc in resectable cases? So this article was published in 2012, where they studied the tumor recurrence after complete resection for Nsclc. 1143 patients were there, of which 33.1% patients had recurrence of the primary cancer. They found out that the pre-op tumor SUV of more than 5 was an increased risk of recurrence. Also, the presence of stage 2, stage 3 disease or sublobar resection or lymphovascular invasion was found to be associated with recurrence. One of the earliest papers on chemotherapy in Nsclc, this was a meta-analysis published in 1995 in the BMJ, which included 52 randomized controlled trials. And the meta-analysis suggested that modern chemotherapy, that is platinum-based regimen, may provide absolute benefit of about 5% in the surgical and 2% in radical RT setting at 5 years. In the 2008, the LACE collaborative group came with this pooled analysis of lung adjuvant cisplatin evaluation, in which they took 5 trials post the 1995 meta-analysis, which included 4,584 patients with a median follow-up of 5.2 years. The hazard ratio for death was 0.89 and an absolute benefit of 5.4% from cisplatin-based chemo was seen at 5 years. The hazard ratio was 1.4 for stage 1, whereas for stage 1B, 2 and 3 was less than 1. Also, this meta-analysis also found out that any of the cisplatin-based chemo had a hazard ratio less than 1 with the maximum benefit of cisplatin vinorelbine of 0.8. Now, this was a meta-analysis published in Lancet in 2014, wherein they studied the preoperative chemotherapy for Nsclc. They included 15 RCTs of 2,385 patients, of which 14 had platinum-based chemo and 1 was docetaxel. They found that there was a 13% reduction in relative risk of death and an absolute survival improvement of 5% at 5 years from 40 to 45%. There was a recurrence-free survival. There was also a time to distant recurrence of hazard ratio 0.69. In this particular meta-analysis, 11 trials were studied for data on extent of resection. There was no evidence of effect of pre-op chemo on the complete resection, and they could not compare the effect of pre-op and post-op chemo directly. They also did not assess the toxicities. In the same year, another review was published, which was pathological response after NACT in resectable Nsclc. This was a proposal to use MPR, that is major pathological response, as a surrogate endpoint. The paper tried to emphasize on the point that there is a very long time from the enrollment to publication of data in Nsclc trials, ranging from 7 to 10 to 11 years. And they also found out that there is an association between major pathological response and improved survival. We are aware of the fact that nivolumab is being used in advanced Nsclc in the second-line setting. This is a 5-year outcome of nivolumab versus docetaxel in previously treated Nsclc. The 5-year OS is 13.4% versus 2.6%. The median OS being 11.1 versus 8.1 months, and the 5-year PFS benefit of 8%. Now, this particular study was published in 2018, which is a pilot study in which 2 doses of preoperative nivolumab 3 mg per kg every 2 weekly was given. There were 21 patients in this study, and out of which 81% were stage 2 or 3A. The treatment-related adverse event of any grade was seen in 23% patients, and grade 3 or higher toxicity was seen in 1 patient. There was no treatment-related surgical delay, and the pathological downstaging was seen in 40% patients. The 1-year recurrence-free survival was 80%, and the major pathological response was seen in 45% patients. This study was published in 2020, which is neoadjuvant atezolizumab and chemotherapy in patients with resectable NSCLC. This was a phase 2 trial. It was a single-arm study in which stage 1B to 3A resectable NSCLC with history of smoking exposure were taken. Neoadjuvant atezolizumab of 1200 mg on day 1, nab-paclitaxel 100 mg per meter square on day 1, 8 and 15 of a 21-day cycle, and carboplatin on day 1, AUC 5 were given for 4 cycles. 30 patients were enrolled. 57% patients had major pathological response. Grade 3 or 4 adverse event, most common being neutropenia, was seen in 50% patients, and raised liver enzyme in 7% and thrombocytopenia in 7%. This was a study on the stage 3A resectable NSCLC, which was neoadjuvant chemo plus nivo in this arm. There was neoadjuvant pacli at 200 mg per meter square, carboplatin at AUC 6, and nivo 360 mg every 21 days for 3 cycles, followed by surgery, and then adjuvant nivolumab 240 mg every 2 weekly for 4 months, followed by 480 mg every 4 weekly for 8 months. To complete 1 year of adjuvant nivolumab. 46 patients were enrolled. It had a 2-year PFS of 77%, and 93% patients had treatment-related adverse event, of which 30% had grade 3 or higher adverse event. The update was published in 21, which said that the 3-year PFS is 69%. Now, this study was published in last year, 21, which was neoadjuvant nivo or nivo plus ipilimumab in operable NSCLC. It was also a phase 2 study. 44 patients were included, in which nivo plus ipi arm had 1 patient had grade 3 diarrhea or colitis after 1 dose, and 1 patient had grade 2 pneumonitis after 2 doses of nivo plus ipi. The major pathological response was 22% versus 38%. However, it was not significant, and pathological complete response 9% versus 29%. With this background, coming to our topic for today, that is neoadjuvant nivolumab plus chemotherapy in resectable lung cancer. The inclusion criteria was adults with a resectable stage 1B to 3A NSCLC with a PS of 0 or 1 and no previous therapy, measurable disease and tissue availability for PDL1. Unresectable or metastatic disease were not included. Grade 2 or higher peripheral neuropathy were not included. Large cell neuroendocrine or serious or uncontrolled medical disorders were excluded. Patients requiring systemic steroids or immunosuppressives, patients who were ALK or EGFR positive were excluded. Pregnant and lactating were excluded. It was an international open label phase 3 trial. The trial was conducted across 14 nations. Initially, there were 3 arms. The first arm was nivolumab 360 milligram 3 weekly plus platinum doublet chemo. The second arm was platinum doublet chemo alone, which was given 3 weekly for 3 cycles. The third arm was nivolumab 3 milligram per kg 2 weekly for 3 cycles plus ipilimumab 1 milligram per kg on cycle 1 only. However, the third arm enrollment ended early because not because of safety issues. It was because of the benefit seen in the first arm as per the phase 2 data. So coming to the study design, after the eligibility criteria was assessed, the randomization was 1:1, either in nivo plus chemo arm or chemo alone arm. A total of 3 cycles were given, and then surgery was undertaken within 6 weeks post-treatment, and optional adjuvant chemotherapy plus minus RT was given as per physician's discretion. The primary endpoint of the study was pathological complete response by blinded independent pathological review, or event-free survival by blinded independent central review. The secondary endpoints were major pathological response, overall survival, time to death, or distant metastasis. And the key exploratory endpoints in this study was objective response rate, feasibility of surgery, adverse events, and predictive biomarkers like PDL1, tumor mutation burden, and circulating tumor DNA. In the Nivo plus chemo arm, non-squamous histology, PEMSIS or paclicarbo was used. In the squamous arm, GemCis or paclicarbo was used. In the chemo only arm, vinorelbin cis, docetaxel, GemCis, PEMSIS or paclicarbo was used. Now, event-free survival, which was one of the primary endpoint, was defined as time from randomization to any progression of disease precluding surgery, progression or recurrence of disease after the surgery, or progression in the absence of surgery, or death from any cause. In the event-free survival, the data on the patient with subsequent therapy were censored. The authors also defined a secondary definition for EFS in which there was no censoring for subsequent therapies. There was also an exploratory endpoint in this study, which is EFS2, in which they defined it as time from randomization to objectively documented progression after the next line of therapy. Now, the patients without documented progression during the next line, but who were started on second next line, were considered to have an event at the start of the second next line. If we look at the consort, a total of intention to treat population was 505, out of which 179 were allocated to Nivo plus chemo arm, and 179 were allocated to chemo alone arm. The basis of calculation of the sample size, the authors assumed that 10% patients in the chemo alone group would have a pathological complete response. If the pathological complete response was significant between the groups, then the EFS comparison would be done with a two-sided alpha of 0.05. So they calculated that approximately 185 events of disease progression, disease recurrence, or death would provide the trial with 82% power and hazard ratio of 0.65 with type 1 error of 0.05. The pathological complete response was compared using Cochrane-Mendel-Hensel test, and EFS and OS were compared by a stratified log rank test. The database lock for pathological complete response was September 2020, whereas for EFS and OS was October 21. The minimum follow-up was 21 months and median follow-up was 29 months. Now coming to the results, at the baseline, both the arms of the study were comparable. Approximately 2/3 of the patients had stage 3A disease, and 1/3 were 1B or stage 2 disease. Squamous and non-squamous were roughly 50% each. And PDL1 status, less than 1% were 43% in each arm. And approximately more than 2/3 patients received cisplatin-based chemotherapy in both the arms. Now, the primary endpoint, which was event-free survival, the 1-year EFS was seen at 76% versus 63%. The 2-year EFS was seen 63 versus 45%. The median EFS was 31.6 months versus 20.8 months with a hazard ratio of 0.63. Now, EFS as per the secondary definition, the median EFS was 31.6 months versus 19 months with hazard ratio of 0.63. The other primary endpoint was the pathological complete response, where the percentage of patients receiving getting PAT-CR in Nivo plus chemo arm were 24% versus 2.2% in the chemotherapy alone group. If we see the subgroup analysis of EFS, the stage 1B or 2 had a hazard ratio of 0.87 and stage 3A had a hazard ratio of 0.54. The benefit was seen across squamous as well as non-squamous histology. If we see the PDL1 subgroup analysis, in patients with less than 1%, the hazard ratio was 0.85, whereas more than 1% was 0.41. And also, if on the basis of type of platinum therapy, for cisplatin was 0.7 and carboplatin was 0.31. Now, the subgroup analysis on the basis of pathological complete response, there were benefit across all the subgroups where stage 1B or 2 had the difference between the Nivo plus chemo versus chemo alone. The PATCR percentage difference was 21.4%, and in stage 3A it was 22%. Squamous and non-squamous both were benefited. And on PDL1 subgroup analysis, less than 1% had a 14% difference, and more than 1% had a 30% difference. Now, assessing event-free survival with the PATCR. So patients with in the Nivo plus chemo arm, PATCR versus no PATCR, the hazard ratio was 0.13 and the median EFS was not reached versus 26.6 months. Now, assessing the depth of pathological response in primary tumor in the overall population, the median residual viable tissue, that is more than 10% of the tumor cells in the Nivo plus chemo arm was 10% versus 74% in the chemo alone group. And PATCR was seen, as we saw, in 24% patients versus 2% patients. Now, depth of pathological response on the basis of stage of disease. In stage 1B or 2, the median residual viable tissue was 28% versus 79%, whereas in stage 3 was 8% versus 70%. Now, this is the subgroup analysis of major PATCR, and in this we find that there has been benefit. Like if we see the PDL1 subgroup analysis, the pathological response rate difference is 15.2% in less than 1% and 39.3% in more than 1%. The OS, this was the first interim analysis for OS, and this was one of the secondary endpoints. The OS benefit at 1 year was comparable, 90.3 versus 90.1. The 2-year OS was 82.7 versus 70%. And the median OS was not reached in both arms. The time to death or distant metastasis, 1 year was 86% versus 76%, and 2 years was 76% versus 57%. Hazard ratio was 0.53. The EFS2, which was defined as objectively documented progression after the next line of therapy, the benefit was 1 year was 87 versus 82%, and 2 years was 79 versus 64%. Hazard ratio of 0.54. Now, the objective response rate was seen in 53% patients in Nivo plus chemo arm versus 37% in the chemo only arm. Progression was seen in 4.5% patient in the Nivo plus chemo arm and 6% in chemo only arm. Now, this was one of the exploratory endpoint, which was circulating tumor DNA clearance. In the Nivo plus chemo arm, 24 patients had clearance, whereas 19 patients did not have clearance. The median EFS in these patients was not reached versus 18.9 months with a hazard ratio of 0.6. And in the chemotherapy group, it was not reached versus 16.8 months with a hazard ratio of 0.63. The patch-CR rate in patients with circulating tumor DNA clearance was 46% versus 13%. And without clearance in Nivo plus chemo, it was 0 versus 4. Now, looking at the treatment summary, a total of 176 patients received treatment in each arm. Disease progression was seen in one patient in the Nivo plus chemo arm and 2 patients in the chemo only arm. Patients receiving adjuvant treatment, 11% received in the chemo arm, Nivo plus chemo arm, whereas 22% patients received in chemo only arm. If we see the surgical outcome summary, patients who underwent definitive surgery were 83% in the Nivo plus chemo arm versus 75% in the chemo only arm. The median duration of surgery was 185 minutes in the Nivo plus chemo arm versus 213 minutes in the chemo only arm. The type of surgery also, the number of patients who had to undergo pneumonectomy was 16.8% in the Nivo plus chemo arm and 25.2% in the chemo only arm. R0 resection was achieved in 83% in Nivo plus chemo versus 77% in chemo only arm. This was the adjuvant chemo dose summary in both the arms. Most of the patients received carboplatin or cisplatin based combination. Like cisplatin was received in 57% in Nivo plus chemo arm, whereas 72% in the chemo only arm, and 42% versus 29% for carboplatin. Now, patients who received subsequent therapy, we can see one striking difference that Nivo plus chemo arm, the number of patients who received immunotherapy was lesser, that is 5.6% versus 23% patients in the chemo arm who received immunotherapy as subsequent therapy. Adverse events. Now, the adverse events of any cause, any grade was 92% versus 97%, whereas grade 3, grade 4 toxicity was seen in 40% versus 43.8%. Treatment-related adverse event was 82% versus 88%, and grade 3, grade 4 was 33 versus 36%. The most common treatment-related adverse event was nausea, which was seen in 33% patient in Nivo plus chemo arm versus 41% patient in the chemo only arm. Now, immune-mediated adverse events, rash was seen in 8.5% patients in the Nivo plus chemo arm. Now, coming to the discussion. So there was a significantly longer event-free survival, that is 31.6 versus 20.8 months with a hazard ratio of 0.63. Patients receive a higher pathological completion rate, that is complete response, that is 24% versus 2.2%. And other outcomes that favored Nivo plus chemo was overall survival, major pathological response, objective response rate, time to death or distant metastasis, and EFS2. The adverse events were not found to be higher in the Nivo plus chemo arm, the treatment related being 82 versus 88, and the surgery related being 41 versus 46. There was a greater clinical benefit in stage 3A patients who were 2/3 of the patients, that is 31.6 versus 15.7. And the benefit was seen across all PD-L1 subgroups, with less than 1% also having a hazard ratio of 0.85. The surgical outcomes were better with Nivo plus chemo. That is, there was a decrease in the duration of the surgery. The number of surgical cancellations were reduced, the number of pneumonectomies were lesser. It was contributed probably because of increased depth of pathological regression and also increased response rate and radiographic downstaging. Now, this was an exploratory study which was on pre-treatment levels of circulating tumor DNA for long-term survival prediction in stage 3A Nsclc treated with neoadjuvant chemo plus Nivo. In this, the pre-treatment levels were an early indicator of recurrence after surgery. The clinical response based on RECIST criteria were not predictive for OS or PFS, and low ctDNA levels significantly improved the PFS and OS as per the study. So ctDNA clearance has a favorable outcome in this study as well. Nivo plus chemo, the EFS was not reached versus 18.9 months, and in chemo alone group, it was not reached versus 16.8 months. This was a previous study, that is circulating tumor DNA in neoadjuvant treated breast cancer, that reflects response and survival, wherein they said that the lack of ctDNA clearance was a significant predictor of poor response and metastatic recurrence, and clearance was associated with improved survival even in those patients who did not achieve a pathological complete response. Now, the strengths of this study was it is an international randomized phase 3 data. It is the first trial on role of immunotherapy in resectable Nsclc in neoadjuvant setting in phase 3. The weakness of the study is that patients with EGFR or ALK mutations were excluded. Biomarker testing before the pre-op therapy was required. So this could result in a potential delay. Opportunities are that there are no Indian data on neoadjuvant immunotherapy in resectable Nsclc. Threat, yes, financial constraint could be one threat. And we saw that the number of patients on subsequent therapy using immunotherapy was lesser in Nivo plus chemo arm versus chemo only arm. So to conclude, neoadjuvant Nivo plus chemo had a significant benefit over chemo alone in EFS, pathological complete response. There was no adverse effect on surgical feasibility, and the surgical outcomes were better. Thank you.
Thank you, Aditya. You could cover the most of the points related to this important trial, and this shows that you had tried to cover all the important points based on the introduction part was also really good. So thanks, Aditya. Now I would like to start the discussion with a comment and a question. So first point, let's see some trial design. In the trial design, you can see that patients, the event-free survival was taken as a endpoint, primary endpoint in this study, along with PAT-CR rates were also included. So what do you think? A primary endpoint of PAT-CR, this has been considered in breast cancer, and there is a long debate ongoing for PAT-CR being a primary endpoint in multiple studies, especially in breast cancer. This is now has been started for lung cancer as well. So let's first have some comments from you, and then if any other consultant or Kumar sir wishes to give comment, then we'll take his comment as well.
Sir, pathological complete response has been shown to be a surrogate to the improved overall survival. It has been seen that patients who have achieved the PAT-CR in this study as well have got a longer EFS as compared to those patients who did not achieve PAT-CR.
Yeah, there was one study which we had quoted before starting this main trial discussion. Can you show that again? Yeah.
Sir, in this study, there was an this was a review basically, in which they found that there has been an association with major pathological response with an improved survival in those patients. Because it takes a very long time for us to publish data on Nsclc trials, the median being between 7 to 8 years.
Yes. Okay. So there have been previous studies, and including a review, we suggest that the pathological response can be taken as a surrogate endpoint. Though the debate will continue, I agree that there will be some disagreement and agreement on the use of these surrogate endpoints. So now the endpoint of event-free survival, what do you suggest? Because usually whenever we discuss any study in neoadjuvant or adjuvant, we try to think about overall survival. This has been discussed for ADAURA trial from a long time. And we have expert comments from Kumar sir and Vijay sir already that in such studies where we know that disease outcomes are not as good, using these endpoints are very important, because overall survival is very difficult to attain the differences because of the different treatment patterns and the drop in treatment arms. So your comments on event-free survival?
Sir, since this treatment was in a neoadjuvant setting, and in a neoadjuvant setting, using EFS would be better, because then we would predict that how early the patient is going to have a recurrence.
Okay. Vijay sir, are you available for comment? Or Kumar sir?
Akhil, can you repeat the question?
Sir, we have long debate on the use of endpoints for adjuvant and adjuvant studies. ADAURA trial, this has been discussed from last 1 year. We had discussions. Now we have a trial for neoadjuvant treatment where PAC CR rates and EFS was taken as primary endpoint. And this is a phase 3 trial, not a small phase 1 or phase 2 study. I wish to get your comments on suitability of these endpoints in such studies.
So, so whenever we have this surrogate endpoint, the few things which we need to see and try to understand what happens to them subsequently. Sorry. So, one aspect is, sure, if we have a validated endpoint, surrogate endpoint, why not? And there are many tumors where we have it. Here in lung, it is evolving, and that's why we keep having this debate, and we'll have those debates. Now, subsequently, another important aspect will be what is the quantum of benefit. So, for example, I give this example. If we have a 5 years overall to think about OS is negative. Let's take it. Let's take the worst case scenario that OS data is negative. And now then let us put it this in the context that patient had a 5 years to live. Now patient lives out of 5 years, 4 years without disease, and another group of patient lives only 1 year without disease, meaning that you have a event-free survival of 4 years, event-free survival of 1 year, and total survival remains the 5 years. Now the question comes that is this relevant? Now, having managed those patients, more in let me put it more in context of palliative patients. So I think so most of you would have not seen the era of only chemotherapy. Most of you have seen era of targeted therapy. But good thing is that you do see good number of patients on chemotherapy today in palliative setting. Now take the patients of partial response of chemotherapy with 30% reduction in tumor size, and a group of patients on targeted therapy with 70% tumor reduction. There is no complete response, but those tumor reductions does lead to different kind of lifestyle for these patients, meaning that indirectly I am saying patient living without disease is important. Now let us put this in a different context, because I said quantum of benefit. Now quantum of benefit, let's put it, patient had to live around 5 years, and patient had in one arm 3 years without disease, in other arm 2.5 years without disease. Now this quantum is different from 4 years versus 1 year. So those quantum becomes very important. Now here what we see for event-free survival, so median is bit deceptive, but good one. The 2-year event-free survival, Aditya, I think so, if I remember correctly, you showed 44% versus 60 something. Am I right?
Yes, sir. Aditya, please show that slide. Yeah.
So it is 45 versus. So what happens at median? It will have around 20 versus 30 months, and it looks okay, good, but not so great. Put it here 45 versus 63, and what it means that you have almost 18%, absolute improvement in survival at 24 years, and looks like it is going to continue with some dip. And here there is a lot of censoring, so it looks like it may continue. Now, if you have a 44% or 45% event-free survival, and then you add around 18 to 20% to the patient, I'm putting 20% just for the sake of understanding. It doesn't mean to say that it is not 18. That is a big number. So this doesn't look like what we have seen in ADAURA, but compare this with almost any other study. Then you realize, oh, there is a quantum jump in the the surrogate endpoint we are looking for, and this surrogate we are talking for OS, but this surrogate, what we are saying, it can be a primary endpoint for the patient. Living without disease is an important endpoint, and then quantum becomes important. Third is, what is the salvage? For example, if you take seminoma, the trials are not versus observation versus treatment. There are a whole lot of trial radiation versus chemotherapy in seminoma, in stage 1 disease, isn't it? When I was getting trained, observation was not or surveillance was not an option. Over the time period, in spite of chemotherapy trial was in fact a negative trial. In fact, radiation chemotherapy did not show it is non-inferior to radiation in those trials, and there are more than one randomized trial on this. In spite of that, it remains not only both as an option, also surveillance also remains an option in seminoma. Why? Because you have very good salvage. In fact, you have excellent salvage in those patients. Now, if we keep all these issues in mind, then we realize what we should do in this group of patients. Coming back to this study, in lung cancer, you do have salvage. Sure, people can argue in this patient only, I think so 20% patient could receive those immunotherapy, but that's also true that lung cancer, there is a challenge. Out of 100 patients in the best of the center, in the best of the situation, and all the treatment available, and this we learned in osimertinib trial, that is in a palliative setting, that ability for them to take those treatment comes down dramatically. That's the reason where your salvage is not so good. Salvage not so good in two settings. One is salvage treatment being there or not, and second is ability to deliver, and both is the issue here. Now, looking all these, it becomes important that how do we interpret this data? So I'm not saying tomorrow onwards every patient we need to be giving, but absolutely there's no doubt that patient needs to be counseled based on this data what we are seeing. So I'm not saying event-free survival every time, everywhere. This is the way to decide treatment. For example, I said, if I have event-free survival of 3 years in standard arm and event-free survival of 3.5 years in treatment arm, I will be concerned. Do we have a good example? We have a good example of sunitinib in kidney cancer. Event-free survival was different. It was statistically significant, the PFS part. By and large, clinicians have not picked up. In spite of that data being for whole year after year, immunotherapy data is being picked up. But in spite of similar data, not same, it was not 18 and 20% like this. It was around a year, that was the difference. They had not proven it again and again. All parameters was not in one direction. So apart from that one endpoint, you look many more things. And that's why when presentation happened, Aditya rightly put it, the CR rates, the distant metastasis-free survival. So these all hints that in this clinical context, this data is important. So that's my interpretation, a bit longer one. My apology. This is for the resident to understand when they infer it. So I don't get into debate of people saying event-free survival should never be a primary endpoint or event-free survival should always be a primary endpoint. Unfortunately, human science doesn't work that way. You can have endpoint and then look things in the context. What are those data? I'll give you another example. There was a TKI developed for kidney cancer. PFS was the primary endpoint. It was statistically and clinically very significant. OS data was reverse because in those countries where the trial was done, sorafenib was available and in the treatment arm, there was no second line treatment for the patient. FDA didn't give approval in spite of PFS being the primary endpoint, and FDA had agreed that that will be the primary endpoint. What it means again that FDA also looks all into the context. So as a clinician also, we should be looking other things apart from only the primary endpoint to understand the primary endpoint.
Thank you, sir. Thank you, sir, for the detailed explanation. This was really helpful and actually eye-opener for many of us. So, Aditya, based on these discussions, first of all, I would like to ask, was there any difference in the surgery patterns in the two arms, chemo alone versus Nivo plus chemo?
Yes, sir. There was a difference in the surgical outcome as well as the type of surgery. The patients who were in the Nivo plus chemo arm had undergone lesser pneumonectomies than the patients in the chemo alone arm.
Yeah.
But otherwise also, surgery rate, was it different? If you leave aside pneumonectomy?
Yes, sir. Patients undergoing definitive surgery was higher in the Nivo plus chemo arm. I'll just show that slide, sir. So patients undergoing definitive surgery were 83% versus 75%, sir.
Do you want to comment upon these surgery differences in the patient undergoing surgery? Was it different for different stages?
Not very sure about that, sir.
Because someone may question you, okay, why stage 1 patient didn't go for surgery after immunotherapy?
Sir, disease progression was 6.7 versus 9.5%, sir, between the two arms.
Sorry, Aditya. So I was just putting you on a spot a bit. So someone may question that you have a 8% or 9% difference in the different surgery, and they say, hey, if your stage 1 patients were undergoing lesser surgery with immunotherapy, should I give it now?
Sorry, sir.
तो देखो ये थोड़ा देखना इम्पोर्टेंट हो जाता है ना, है कि नहीं?
जी सर.
चलो.
Sir, and if we see the type of surgery, 16.8% underwent pneumonectomy and 25% underwent pneumonectomy in the chemo alone group.
Yeah, that is fine. That is fine. Just one thing, if a patient of stage 1 or stage 2, there are two arms in the study. One arm is chemotherapy, another arm is Nivo plus chemo. Though the standard of care is not usually giving neoadjuvant treatment in such patients. So how will you explain your surgical colleague that this treatment might help and will not deteriorate the patient? How will you explain your surgical colleagues?
Sir, based on the data from this study, there has been a radiographic downstaging of the disease. There is more number of R0 resections based on the data from this study. And the median duration of the surgery, the type of surgery has also been lesser morbid in the Nivo plus chemo arm.
I think we need to see specifically for stage 1 and stage 2 separately than stage 3. Then it might help us more. Sir, your comments?
So I think so. I know Akhil was giving you a good hint that, see, when you have a data, how you discuss in the clinic, because you may just give me a second. Hello. So so how do you discuss in the clinic? Because go to the surgery versus no surgery. अब देखो अगर आप क्लिनिक में डिस्कशन, जैसे मैं मान लो कल क्लिनिक में डिस्कशन करूंगा ऑन न्यू एडजुवेंट कीमोथेरेपी 25% पेशेंट नॉट रिसीविंग सर्जरी, वो बोलेंगे अरे भाई साहब 25% पेशेंट, हम तो 100 हर एक 100 जो आएंगे सबकी सर्जरी करता हूं मैं, तो ये 25% पेशेंट को सर्जरी नहीं करेंगे, ये कैसे होगा भाई? कैन यू इमेजिन ये डिस्कशन? वो बोले हम पेशेंट जो आते हैं 100 पेशेंट आएंगे, अगर सर्जरी हम अपफ्रंट करेंगे तो हम सबकी सर्जरी करेंगे, आप अगर कीमोथेरेपी या न्यू एडजुवेंट कुछ देते हो तो 25% को तो हम कर ही नहीं पाएंगे। अब कितनी ये तो सेंसेशनल, ये देखो ये आज तक की न्यूज हो जाती है फिर, तो इसलिए ये बड़ी इंपॉर्टेंट होती है कि अब ये कैसे आप इसको डिस्कशन करो। तो डिस्कशन ये कि देयर इज अ स्टडी ऑफ एडजुवेंट वर्सेस न्यू एडजुवेंट, ठीक है, उसको नैक्ट स्टडी बोलते हैं, ठीक है। तो उसमें देखने से ही लगता है कि भाई आप न्यू एडजुवेंट करो एडजुवेंट करो, दोनों की आउटकम सिमिलर रहती है, उसमें फर्क नहीं है, इसलिए न्यू एडजुवेंट एज अ ऑप्शन ऑलवेज रिमेन्स। देन कमिंग टू नेक्स्ट पार्ट, एंड न्यू एडजुवेंट में हमेशा है कि जो पेशेंट्स हैं ऑलवेज देयर इज, इसमें थोड़ा सा कम है, इट इज ओनली यू नो ऑलमोस्ट आफ्टर न्यू एडजुवेंट थेरेपी, जो इसका नाम क्या है, ऑलमोस्ट 10% 15% पेशेंट्स है ऑलमोस्ट इन एवरी स्टडी दे हैव नॉट अंडरगॉन सर्जरी। तीसरी चीज है कि अगर सारे स्टेज 1 2 एंड अर्ली स्टेज 3 पेशेंट सर्जरी जाएं तो ऐसा होता नहीं। जैसे फॉर एग्जांपल टाटा हॉस्पिटल में कितने पेशेंट्स स्टेज लंग के ये होते हैं, रजिस्टर होते हैं? यानी थर्ड ईयर, कोई थर्ड ईयर है हमारे यहाँ? हाँ मिनट, मिनट, अरे मिनट तो कुछ,
हेलो, यस यस यस
पेशेंट्स लंग के आंसर के हमारे यहाँ रजिस्टर होते हैं पर ईयर? एनी आइडिया?
सर ऑल स्टेजेस, फॉर ऑल स्टेजेस।
हाँ 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 ऑल स्टेजेस, मैंने कोई बोला नहीं, जो जो तुम्हें जो ध्यान आए बता दो।
सर अराउंड 10,000 पर
10,000
10 to 15,000।
चलो आलोक, एनी नंबर?
सर अराउंड 5,000 per year।
5,000 पर ईयर। और राहुल? चलो 10,000 से 5 आ गए, 5 से लेट्स सी। राहुल कितने पेशेंट लंग कैंसर के रजिस्टर होते हैं इन टाटा में?
सर अराउंड हेलो,
हाँ हाँ बोल दो कुछ नंबर बता दो।
सर 5,000।
5,000, अच्छा तुम कम करने को राजी नहीं हो रहे? अच्छा, और कोई नहीं, और कोई थर्ड ईयर नहीं हमारे? नहीं, चलो तो देखो जो हमारे यहाँ रजिस्टर होते हैं 2,500 होते हैं। अब देखो तुमने 10 से 5 किया, 5 से तुम हाफ कर देते तो तुम सही हो जाते, लेकिन तुमने किया नहीं। चलो अगर 2,500 पेशेंट्स अगर रजिस्टर होते हैं, कितनी की सर्जरी होती है? एनीवन? राहुल तुम चालू हो जाओ। हेलो, हाँ सृष्टि बोलो।
15% to 20%।
हाँ सॉरी, कितना बोले राहुल? कितनी सर्जरी होती है लंग कैंसर के हमारे यहाँ?
सर 5 to 10%।
अरे 5 to 10% नंबर तो बताओगे तभी 5 to 10% आएगा ना। 10% अलग हो गया, डबल द नंबर बता रहे हो, 5% आधा हो गया।
सर 500
एक्यूरेसी होनी चाहिए। 500 पेशेंट की सर्जरी, 500 सर्जरी होती है लंग कैंसर की, बहुत बढ़िया। अच्छा और बताओ इसका कौन, आलोक कितने पेशेंट लंग कैंसर की सर्जरी होती है हमारे यहाँ पे?
250 to 500।
250, चलो इसने आधा कर दिया, पहले से बोला सर आपने आधा वाला बताया तो हम वही फॉलो कर लेंगे। मिनिट?
सर अराउंड that much only, sir, 250 to 500।
250, चलो ये करने को राजी नहीं है, रिवर्स में भी वही सेम चल रहा है। और कोई नहीं थर्ड ईयर है? कोई नहीं है मिनिट? और कोई थर्ड ईयर नहीं हमारी यूनिट में? 3 ही लोग हो।
सर 400
मानवी, चलो बहुत बढ़िया।
सर अराउंड 100 to 150।
अच्छा चलो थैंक गॉड, कोई तो नीचे आया। चलो 80 पेशेंट की सर्जरी होती है हमारे यहाँ, 80 से 90 पर साल। अब देखो 2,500 में से हम बोल रहे हैं कितना परसेंट होता है स्टेज 1 2 अर्ली 3? कुछ परसेंटेज सोचो, 20%, 25%, 30%? हाँ कितना होता है राहुल?
सर 25% स्टेज
25%, चलो 25%, 2,500 का 25% कितना होगा?
500।
2,500 का पूछ रहा था मैं, 2,000 का नहीं पूछ रहा था। तो मेरा मैथ्स भी खराब करोगे तुम। ठीक है, तो 600 पेशेंट्स की सर्जरी होनी चाहिए। अगर हम सोचते हैं ये सारे पेशेंट जो सर्जरी के लिए होनी चाहिए स्टेज 1, 2 एंड अर्ली 3, मैं स्टेज 3 बी की नहीं बात कर रहा हूं, ठीक है, तो उसके हिसाब से देखो 600 पेशेंट की सर्जरी होनी चाहिए, होती 80 की है। तो हमने क्या सीखा है कि भाई जो सारे पेशेंट जो स्टेज 1, 2 होते हैं 3, वो सबकी सर्जरी हो जाती है, ऐसा नहीं है। समझ में आई बात? तो these are the discussion, if you know then you can have an argument in the clinic कि भाई हम इस चीज को कैसे अडॉप्ट करें। अदरवाइज you will be caught here and you are stuck here कि अरे 25% की सर्जरी नहीं हो पाती, हम तो सबकी सर्जरी करते हैं, और लंग में खास वेटिंग लिस्ट नहीं है। तो हम ये भी नहीं बोल सकते हेड एंड नेक जैसा कि देखो हमारी तो बड़ी लंबी वेटिंग लिस्ट है 3 महीने की, इसलिए हम सबको बाहर भेजते हैं। नहीं, ऐसा नहीं है लंग में, क्योंकि कुल मिला जुला के 80 पेशेंट की हम सर्जरी करते हैं, 80 से 90 ये पर ईयर। तो समझ में आई बात कि ये जो 75% है, अगेन इट इज अ रियलिस्टिक नंबर इस तरह के पेशेंट्स में। एंड अखिल ने बिल्कुल सही बोला कि स्टेज 1, 2 बिकम्स मोर इंपॉर्टेंट, क्योंकि स्टेज 3 में ज्यादा इश्यूज हैं सर्जरीज में, इसलिए लोग ज्यादा कंसर्न रहते हैं। जैसे निमोनेक्टमी उन्होंने 25% की है, हम हार्डली निमोनेक्टमी करते हैं। 25% तो कभी मुझे ध्यान ही नहीं, कोई चांस ही नहीं है हमारा नंबर होने का लंग कैंसर का, मे बी लेस देन 5% होगा निमोनेक्टमी, मुश्किल से 4, 5 या 6, 7 हम करते होंगे पूरे ईयर में। तो स्टेज 1, 2 यस, अगर आप वो देखोगे दैट विल बी मोर रियश्योरिंग एंड देन यू विल बी मोर you will have more argument in the clinic कि देखो इसको कैसे अडॉप्ट की जाए apart from the end point। तो अखिल रेज अ वेरी वैलिड पॉइंट कि देखो इन चीजों की आपको जानकारी होनी चाहिए when you want to implement। अखिल, again I took a bit longer time।
Thank you, sir. Thank you for taking it longer and bringing about the very, very relevant points, sir. Any other comments from anyone? I think it's close to 9:25.
एक क्वेश्चन पूछूं इसको, थर्ड ईयर राहुल, अब देखो न्यू एडजुवेंट का डेटा भी आ गया, एडजुवेंट का डेटा भी आ गया, दोनों का वही एंड पॉइंट है, क्या करेंगे? हाँ राहुल।
Sir, we'll prefer neoadjuvant, sir.
रीजन?
Sir, one, we can assess whether the neoadjuvant chemotherapy is working or not. And we have a availability of PET-CR, which can give us an idea ki whether the chemotherapy which we is given as the anesthetic setting is working or not in that particular cancer.
और कुछ? Was the PD-L1 a predictive factor for patient's outcome? Aditya? Or any PD-L1 benefited?
Sir, all the patients were benefited. Even patients less than PD-L1 1% were also benefited.
Leave it. Rahul, was it true in the adjuvant trial? अब देखो एक ना मैं बोलूंगा थर्ड ईयर्स को एक टेबल बना लो। देखो ये तो देखो क्वेश्चन आएगा ही, अगर ये जनरली आई होप जनरली एडवांस स्टेज आता है, बट अर्ली स्टेज की आएगी, ये नई डेटा आई हुई है तो मोस्ट ऑफ द एग्जामिनर रिमेंबर्स है, तो उसमें अच्छा है कि एक टेबल बना लिया कि एडवांटेजेस ऑफ न्यू एडजुवेंट एंड डिसएडवांटेज ऑफ न्यू एडजुवेंट इम्यूनोथेरेपी, नॉट इन जनरल, इन जनरल तो आप लोग को आता होगा, देन एडवांटेजेस एंड डिसएडवांटेजेस ऑफ एडजुवेंट, उसके जो थोड़े से कहते हैं रेलेवेंट पॉइंट हैं कि स्टेज 1, 2 में क्या करना चाहिए, EGFR का क्या हुआ, PD-L1 का क्या हुआ, कितना टाइम तक देना पड़ता है, ये सारी चीजों को थोड़ा सा याद करके अगर ध्यान करोगे तो यू विल हैव अ टेबल सो दैट यू कैन दैट बिकम्स इंपॉर्टेंट इन द क्लिनिक आल्सो, बट एग्जाम के लिए थोड़ा सा इंपॉर्टेंट हो जाता है ना, यू डोंट वांट टू गेट स्टक विद इट। ठीक है, थैंक यू अखिल। हाँ,
So thank you, sir. So, Sir Rahul, this is very important for discussion even in breast cancer, as we know. So some points are some similar, and some additional points are also given a hint. So I think you can make a table and post in our group so that which can be discussed further. So that
Yes.
might